Hi, my name is Dr. James. I am the managing partner of Integrated Physicians Medical Group. I am a chiropractic neurologist, and I've been in practice for 30 years. And I'm super excited to introduce to you today my colleague here, my partner in crime here, Dr. Jason Kelberman, who I have known for over 30 years. Oh my Lord. And we're just gonna have a casual conversation to introduce you to us and what it is that we do here. So Jason, why don't you tell the folks here a little bit about yourself and what you're doing here.
You know how excited I am to be here, obviously.
And I am to have you.
Yeah, it's a great mixture of specialties, and I think everybody out there is going to be excited to hear about all that we have to offer them here. My background is in applied kinesiology, and kinesiology is a study of the movement of the body, so it involves your muscles. So while Dr. James's specialty is neurology, and boy, he can do everything from the brain on down, I've kind of worked the other end of the human frame. I kind of start from the feet on up. So for runners and people with peripheral neuropathy and just gait-related disorders of all kinds, the combo, I think, is enriching for everyone. So we do foot orthotics, we do rehab, we work together as a team, we communicate for the betterment of the patient, and we very frequently bounce ideas off of each other, which is really great for all you docs out there living on your own. It's just great to have another doctor to bounce things off of. It's just really helpful. I can't even emphasize that more. And that's why I'm excited to be here.
So, got it. So, me too. Feelings likewise. So, what is it that, who's your ideal patient? What do you love taking care of? What do you love treating?
For me, the patients that I love to work with are people who want to get well. I don't want to want it more than them. I don't want to work my patootie off in every way possible, only to find out that the person who says they want to get well won't do all the things that it takes to be well.
Right, that's the thing about how we practice, right? Which is there isn't a lot of passivity to it. So we're engaging the patient in getting well. They've got, as you said, they've got to want it because they're going to have to do some things to get themselves out of the position that they found themselves in, right? So whether that's dietary changes or lifestyle changes or specific exercises, et cetera, there's usually some changes that are coming down the road for people, right?
Right.
That's that old crazy thing of, the definition of insanity is doing the same thing over and over again and expecting a different result. So the approach, and it's really cool to have you in the office because while there are similarities in some of our approach, there's also clearly some differences in how our viewpoint. And so when you have a doctor look at somebody with a different viewpoint, obviously you can get a more well-rounded approach to getting better, right? So I know you've referred me some patients and I've referred you back some patients, and I think it's just to the betterment of everybody here. So from a condition point of view, are there certain conditions that you either have a proclivity for, enjoy taking care of more, and get more of a sort of a just like doing than others?
Well, as you know, I specialize in peripheral neuropathy.
I do know, but nobody else knows, so I had to ask the question.
Okay, so for all of you out there who are either watching, listening, etc., peripheral neuropathy is damage to the peripheral nerves that leads to really bad pain, numbness, tingling, all kinds of horrific things that prevent you from walking and balancing and getting on with your life. And if you've watched TV, you've seen commercials that are telling you that this condition is becoming more and more prevalent because of diabetes becoming rampant in our society. So yeah, that's one of my specialties. As a result of that, I got to be excellent with the care and rehabilitation of feet. So we have a complete foot rehab program that we can offer anybody.
So what is it that you do different relative to peripheral neuropathy? Because I've dabbled in that a little bit, and people who are suffering with peripheral neuropathy, they're usually pretty hurting and they really don't get results elsewhere. They're pretty well left sort of out in the wild or out in the cold, if you will.
Right.
So what is it that you do different that allows people, for you to get the results that you're getting?
Well, first off, I put them in the category of having a chronic disease process, okay? So it's not the type of patient where you can just give some exercises or just do a couple of modalities with, although they are very helpful. You have to do metabolic work with them. You have to get them to change their diet. You have to put their body in a position where it actually has the raw nutrients to heal. Right. So I think that because of the years that I've spent doing that, I've developed some pretty good systems, and we get really excellent results. And also the ability to properly treat the feet is absolutely crucial. And so I've developed some brand new techniques that are comfortable for even nerve damage patients in severe pain to tolerate.
That's awesome.
Yeah.
I found for myself that, like, for particularly with somebody who's got an autoimmune condition or they're a diabetic, that my preference usually for treating them is to take care of the metabolic disorder that's driving the dysfunction, right? So some people come in and, you know, they're like, take care of my feet, but the problem is they're a diabetic. And if you don't take care of their diabetes, it's going to be a temporary solution. Right. And I know you're in agreement with me. We don't want to be just that Band-Aid, right? So, and if somebody is suffering with diabetes and is expressing it in the form of, let's say, peripheral neuropathy, they're going to have to make lifestyle changes. They're going to have to be dietary changes. Sure. There's just no easy solution for that, right?
Here's a typical scenario involving that same axis. Patients coming in with statin drugs. Mm-hmm. How prevalent is that? Everywhere. Well, particularly since now Big Pharma wants everybody to have a cholesterol level under 150, which only benefits one industry or one group, and that's Big Pharma, right? Should we talk about that for 30 seconds?
We should talk about that.
Okay, here's my opinion about that. Mm-hmm. High cholesterol all by itself is meaningless without doing a lipid profile to see if the actual particles of cholesterol that you have are good or bad. Because theoretically, you could have a cholesterol of 400, have healthy particles and be totally fine, eat bacon the rest of your life and be totally healthy. Conversely, you can have low cholesterol, have bad particles, and you're at high risk and probably going to have major heart failure in your 40s, 50s, or 60s. Right. You agree with that?
Yeah, to a degree, certainly, right? Like there are familial type of hyperlipidemias. Like if somebody's got their triglycerides at 1200 and their cholesterol is 400 or 500, they may need some sort of medication to drive that down.
But the problem is that the MDs are being forced to use them on most people who just have a number that's quote unquote too high.
No question, and it's only one model of what causes heart disease, right? The cholesterol
So here's
model.
where I was going with that. So I will often get a case where they're on statins that are creating their peripheral neuropathy because it's notorious for doing that, okay? So I sometimes have the privilege of sending that patient back to their doctor to pull them off of it. Because as you know, as chiropractors, we don't prescribe drugs, so
we don't take them off.
Exactly. So I send them back to their primary physician who says, okay, great, I'll take you off the drug. They make an assumption that just because they're taking you off the drug, that all of your symptoms are going to reverse. And it's almost never the case. I've had 3 cases in 8 years that happened. And they were just miracles. I
don't know if you see this too, but along the lines of statin drugs, we know that statin drugs cause peripheral nerve damage, but they also cause muscular damage, right?
Absolutely.
And so people who are on statin drugs often have, neuromuscular issues and back pain, and neck pain is associated with, and sometimes even atrophy. And some of these drugs, like Lipitor, now is just actually, it was actually a few years ago, they discovered that it was actually causing diabetes in women.
Earlier than usual.
Right, and it's a mainstay sort of drug to give to diabetics, right? Because what happens with diabetics is they have these insulin surges, they develop insulin resistance. As a consequence of the insulin resistance, their liver starts to produce more cholesterol, right? So the doctor sees an elevated cholesterol level and he's automatically putting them on statins. Right. But if you're a diabetic with elevated insulin levels, that's not going to be an approach that's going to be very beneficial or helpful to you. So, so in agreement that, from a functional medicine point of view, again, we want to get to the cause of if your cholesterol levels are high, maybe it's a consequence of your eating habits, of not working out properly. There's a whole host of things to take a look at there, right? Or is there a breakdown? Do you have a methylation issue? Do you have gut issues that are driving it? Are you not absorbing fat properly? Exactly. So there's a whole load of things to be looking at, right? And some of those things obviously manifest in peripheral neuropathy. I like what I see in terms of how you're treating the peripheral neuropathy, because you not only attack the feet, but you are also addressing the metabolic component of it. Yeah, that's really cool.
I think that just doing one of those approaches is far less satisfying and effective than doing all that's necessary at the same time.
I agree. Yeah. The thing that I have said to patients and have seen with patients a lot is that when people are suffering with peripheral neuropathy, it isn't just happening in their hands or their feet. It typically isn't isolated. So you can have what we call autonomic neuropathy, which means it's affecting your organs. In the peripheral neuropathy is affecting your brain. It has to, right? Particularly if it's a diabetic kind of peripheral neuropathy.
Unfortunately, I've kind of gotten to the place where I frequently view it as a global neurodegenerative process.
Well, I don't know why, unfortunately, it is. It is.
Yeah, especially in advanced age patients, et cetera. But
it is.
Yeah.
So let's talk about some of the other things that we handle here, right? So we have patients who come in here all the time. They've been to chiropractors, they've been to physical therapy, they've been to acupuncturists, and they've got really bad debilitating back pain, and sometimes they've got what we call a radiculopathy or sciatica. They've got pain going down their leg or going down their arm or going into their fingers. And so just from your point of view, I'd like you to talk a little bit about how we all work together to help people with that.
Right. So, in fact, I just had a patient in the same boat with 2 bulging discs and long chronic history. My personal approach is that I like to get the legs and pelvis working as effectively as possible. Most of us have one or more issues with one or more of the legs. There's nothing better than balancing all the foot, knee, hip, leg muscles, getting the pelvis working correctly, and then decompressing the damaged disc so that you can rehydrate that and get that to perform and work normally again.
Agreed.
Yeah.
Agreed. So what I see a lot is that patients are dismayed by the care they've gotten, but often they're not really even evaluated very thoroughly. Like nobody's looking at the kinetic chain, they're not looking at their gait, they're not even doing a full neurological exam to see what's the locus of the problem. They're not triangulating it with an imaging study like an MRI, and so they're not getting the result that they want. And so I think the approach that we take where we look at somebody and we do a thorough workup on them, and then we send them out for an MRI, and then not only do we do, and I think we have some of the most sophisticated decompression technology available now, but all the other therapies that I think that we utilize around that, as you've spoken to, whether it's dealing with the foot or doing something called active therapeutic movement, which is a therapy device, which actually I'll take a moment and talk about that now. So what happens when patients injure their back, right, is or you injure any joint, literally, you are getting pain sensation, pain signals going up into your brain. And that causes a consequence of output from your brain to try and compensate for that, which usually means that your muscles are firing not in a way that's really coordinated. And then a patient may go to some therapist who will see a weak muscle and try to strengthen up that muscle, when in fact it's a misfiring pattern.
Correct.
So the beauty of the ATM, particularly as it speaks to the spine and the shoulder and the hip, is that we can normalize those firing patterns. And it's quite simple in its, as you know, it's quite simple in its sort of application.
It's beautifully simple.
It's beautifully simple in that we have somebody in a weight-bearing position, and all we do is we stabilize the joints that are unstable. So if it's the spine, we will stabilize you here. If it's a hip, we stabilize your pelvis. And then once we have you pain-free, we have you activating that muscle in a previously painful range of motion.
Right.
And we see almost instantly, sometimes in a set of 10, where somebody can barely move their head back, they'll go like this and go, oh my gosh, or they're standing before us and they can barely move back, and we know we didn't strengthen their muscles in one set of 10. Right. If it were that easy, I think we'd all look like Greek gods and goddesses, right? You walk by like Gold's Gym with a Foster's Lager and look how great I look. So there's another mechanism, and that's the way that the central nervous system basically outputs to those muscles. That normalization not only gives you greater range of motion, but it actually retards the ability for those muscles to cause further joint breakdown and more pain.
Right. But the reality is, because of the technology that we're comfortable using, we can simplify that for the patient so that they're going to get the results that they haven't gotten elsewhere.
Right. We use a series of different isometric exercises also, and we do them with engaging the brain and doing gaze stabilization exercises. We have a laser that we use not just for treating inflammation, but we actually have a laser that helps us.
Love the laser.
Oh, but I'm talking about the different laser that we use for coordination for movement. We have one on the wall over here where we basically work on coordinated movements to get the brain, the eye, and the spine to be working together properly. And then we have the Class 4 laser that you love. Why don't you talk about the Class 4 laser for a second, since you love it so much?
Oh gosh, I love it so much. I've been using lasers for at least 25 years. When they started out, they were so weak, a treatment took a half hour. And maybe it delivered a quarter of a watt, or I don't even remember the joules.
It was like an LED pointer.
It was just, they called it photonic stimulation. And that's all we had. We thought it was great. We could do cranial nerves and so forth. So we thought. The technology kept improving. The function kept improving to the point where now we're using a Class 4. And what I want everybody to understand about that is that it gives us the ability to deliver the photonic energy, the light energy, deep into the tissues where we need to get at it. Unlike cold laser, which has been very popular, let's face it, cold laser doesn't penetrate. It's a great superficial treatment, might be great for some acupuncture treatments, etc., but it's not going to get into the discs, nerves, tendons that are damaged, okay? Then patients ask me, so what does that do? So I like the analogy of sunshine on a green leafy plant. Everybody understands chlorophyll and photosynthesis, okay? So the sunshine comes in, the green leafy plant changes that chemically. The same thing happens with laser in the human body, only for us, we get an oxygen release and we get a stimulation of circulation and a bunch of other great things that will help the healing process.
The low-level lasers, were used a lot in burns, right? So there wasn't a high penetration value, but they didn't need to because they were at the dermis. And there's
Not that you and I were treating burns.
I was never treating burns. But the newer literature that is coming out now too is also talking about that we're using lasers for patients who have had traumatic brain injuries. So as you know, I like treating those traumatic brain injuries. So if somebody's suffering with the traumatic, and it doesn't even have to be that, it could be a dysautonomia, meaning somebody has, they've got dizziness, or they've got digestive issues, and they've done everything that possible. Maybe it's actually brain-based, or they have an autoimmune issue. It could be something that we attack with functional medicine. It could be brain-based also. Right. But people who have unsteadiness of gait, imbalance issues, maybe difficulty with speech, there's all sorts of things that can occur with a traumatic brain injury, but that can occur just as a consequence of daily living, right, and being exposed to different things. But as it speaks to TBIs, traumatic brain injuries, the literature is now out that lasers are effective in actually healing some of these injuries. So really nice.
And most people aren't treating brain injuries; they're just waiting for it to resolve.
Right.
So it rarely does.
True. So one of the diagnostic capabilities that we have now is we have a force plate in the office. What it is it's a platform that has very sensitive sensors in the different corners, and it picks up very minute movements. And so what it can do is it can give us an idea of a couple of different things. So I'll throw out some big words, something called a center of pressure. So it's basically where your brain thinks your body is in space, right? So we can look at, are you sitting back on your heels, if you will? Are you sitting on your toes? Are you balanced more right or more left?
Sure.
But also for our elderly population, it gives us something called a fall risk assessment.
Exactly.
So basically, all you're doing is you're standing on a plate. It's not unstable. We can put an instability platform on it, but it's just like standing on the floor, and it's measuring as you're standing there. It's measuring how far you move. Everybody has a little bit of a sway, right? Like if you ever just stood still and closed your eyes, you can feel that your body moves a little bit. A little bit of movement is okay, but there's a moment where we start to exceed that. I guess what we would call like a center, a safe zone,
right.
and we're at risk for falling.
So this is a real simple way for us to evaluate that.
It's a really simple way for us to evaluate. Basically, somebody stands there for about, it's 3 or 4 trials at 20 seconds.
Yeah.
And it'll give us a score whether you're at high risk or low risk for a fall. But it also, from my point of view, tells me neurologically how your brain is working or not working. Because how your brain knows where you are in space is really through 3 modalities. It's either through your vision, through your middle ear, your inner ear, or it's through the joints of your muscles and your skeleton and your spine. So when we put you on the force plate, we take your vision out. So we're primarily relying on your proprioception, those joints and muscle spindle cells, and we're relying on your middle ear. And so it gives us a really strong idea of, well, if you start swaying in a certain direction, it'll tell me which part of your vestibular system is weak and needs to be strengthened. And so it's really a valuable tool for us, both to assess where the weakness is, but
an objective criteria for, are you improving as well?
And it's used in all kinds of vestibular clinics. Our application is just a little bit different. I don't know. I use it because I like to look at how the brain is functioning. I like to see where they're at, and I like to look at their centers of pressure. You use it for your peripheral neuropathy.
I use it for gait-based issues. For I'm treating a lot of elderly patients, and so they should be evaluated for fall risk properly, and so I can also base my progress with them on whether their feet function better. This is just another way we can test how well that's changing.
Honestly, like everybody over 70 ought to have this fall risk assessment.
I totally agree.
Because we do know the comorbidity. Once somebody is in that age range and they fall and they break a hip,
sure,
they're usually not around for much more than a year, if that, right? So it's really scary. It's one of the biggest reasons why elderly folks are going into the hospital as slips and falls. So if we can evaluate that and preempt that,
sure,
and maybe not wait until you're in your 70s, but look at it when you're in your 50s or 60s, or certainly if you find yourself losing your balance or losing your coordination, there's a reason for that, and we need to look at that. And there's lots of things that we can do for you outside of the traditional realm, if you will.
And if you're over 60, stay off ladders. Just stay off ladders. I don't care who you are.
Hire somebody to clean your gutters, right?
Exactly.
Good advice. It's just sort of like at some point you'd stop renting your own U-Haul and moving your own stuff. At some point you hit an age where you need somebody else to just do it for you.
Exactly.
So I like the force plate for me relative to the TBI because I can then match that up with, if somebody has a traumatic brain injury, I can match it up with eye movement activities or improper eye movement activities or lack of coordination. And so for me, it's always, I like the gathering of the evidence to point me in the right direction to what do I need to treat with that person? Where do they get the most bang for their buck? What's going to be most cost effective, most efficient, and most effective for them?
Right.
And a lot of these technologies, unfortunately, they're not covered by insurance, right?
Unfortunately.
They're not.
The good stuff isn't.
The good stuff isn't, which is
Right.
kind of crazy. And I know it drives patients crazy that we have
Yeah.
all this incredible technology, and then they're going, why doesn't my insurance pay for it?
Why doesn't Medicare cover it? Why doesn't this cover it? I'm with you. You know, I'm practicing 32 years as well. We went from having great coverage to not having coverage.
So what do you tell your patients?
I let them know that we're doing newer work, and you know it takes years for the newer work to be accepted and to be covered. And quite frankly, with the state of our country right now, I don't see that more things are going to get covered because they're trying to cut benefits left and right. So
Yeah.
I'm not optimistic in that field.
There's no money in getting people well. So there's money in keeping people sick.
When
and
we
keeping them
save
trapped.
people from surgery, we're the bad guys in certain people's opinions.
Our system is it's so flipped, and I was just speaking about this to a friend.
It's
just a little-
disease-based, not health-based.
Yeah, when did eating well and exercise become alternative, right? And surgery and drugs were mainstream. Like how did we allow ourselves to be brainwashed to allow that to occur? To think that, oh, we're not covering the alternative. Why is what we're doing alternative? We're helping people get well naturally without interventions that are surgically or surgical interventions or drug
in other countries of our world, that's their approach. In other countries of the world, the building codes include infrared saunas in your bathrooms. I mean, there are so many things that are being done right around the world in health that we don't listen to in the U.S. because we're arrogant.
Yeah, it's really a shame, and I feel for patients when that they may get $100,000 surgery covered at 80%. But here's the upside to that, right? That no insurance ever covers everything. In fact, my insurance coverage has gone up and up over the last several years, right? And it got to the point where I was spending almost $1,500 a month for a $13,500 a year deductible, which means to say that by the time I got to November, December, I'm already out of pocket $30,000 before it picks up 80%. So let's say I needed a surgery and it was going to cost $100,000. I'm out of pocket 30. It covers 80%. I'm out of pocket another 20,000, right? So it'll cover 80, and now my surgical out of pocket is going to be $20,000. And none of the things that we do here are even remotely related to that. Even though a lot of the people who come here for disc problems, disc herniations, disc ruptures, spinal stenosis, sciatica, all those things, we're able to handle non-surgically. It's not even. It's usually at the bottom end or even less than their typical surgical out-of-pocket expense. So it really is, for most of our patients, it really is a no-brainer. We don't make that the big thing.
Stay healthy.
Stay healthy is not a bad idea, right?
Yeah.
How do you stay healthy?
I used to have one idea about what that meant, and as I've gotten a little bit older, I've changed my viewpoint slightly about what that is. And you know, we think of staying healthy as eating right, sleeping right, getting the right exercise, trying to reduce stress. But taking care of all of those things that affect us along the way. As we age, you're going to find things go awry. I don't care who you are. Right. Your eyes, your cholesterol, your diet, your colon, whatever it turns out to be. You know, last year I had to have my eyes surgically replace my lenses because I had cataracts. That was out of the blue. That happened within 2 years. If you had asked me the year before that, I'd say I'm perfectly healthy.
Right. By the way, so just to clear up, because I sound like I'm like Mr. Anti-Surgery Medicine, like that's a miraculous thing. Like without that, you wouldn't be able to see right now, right? So clearly there's look, surgery is a tool. To me, it typically for things of the nature that we deal with, not your eyes per se, but musculoskeletal stuff, neurological stuff, that should be the last tool that we pull out of the toolbox, right? Because the consequence of that going wrong is where the problem really lies, right? The consequence of all the things that we do in this office here are the risk-benefit ratio is really like surgery. The risk is really high, the benefit's here.
Once it's done, it's done. You can't undo it.
That's right. That's what I tell patients. If it goes wrong, there is no turning back the clock, right? But thank God for things like that. Like I had LASIK surgery, but now my eyes are bad again. But when I had it done, for me, it was miraculous to not have to wear my glasses all the time, you know? So, you know, I think health fluctuates and is different as we age, and we need different things as we age. But it's interesting. Oftentimes, what I find is people say to me, "I eat really healthy." As an example, I mean, I eat lots of grains and I eat lots of plants, I eat lots of that, and yet they come in and they're really sick. And you know, I think it's when we're dealing in that world, it's very individual. Like some people will do really good on a vegan diet. And some people for a while, and some people, but I think genetically there's probably a pretty narrow group of people who really do well on that kind of a diet for a whole host of reasons, right? For me, it's a challenge when I get somebody who's really, really ill and they're a vegetarian, let's say, and then we test them, we find that the thing that's driving their inflammatory process, that's just driving their sickness, is potentially a lot of grains, right? And we see that a lot. And part of this that people need to understand is that grains and seeds and nuts, they can't run away from the enemy. They can't run away from a carnivore, right? So they've developed this thing phylogenetically, these anti-nutrients that make it difficult for them to digest. If you already have a weakened digestive system and you're putting these anti-nutrients into your gut, it acts like a hole punch. It starts to basically destroy your gut, and now you get these undigested proteins into your system.
For everybody listening, that's called leaky gut.
Leaky gut. So you could be eating well, but the foods that you're eating may not be making you well for you. They may be making you sick, right?
Exactly.
And so you got to be willing to take a look at that and not be so attached to maybe a certain dogma about that.
I tell my patients this. People around the world like to eat everything on the planet. For example, in China, they'll eat monkey brains. And they'll make claims about eating monkey brains.
This doesn't appeal to me at all.
It doesn't appeal to me at all, though sweetbreads in the old days. But hey, my point is that while we are omnivores, it doesn't mean that we're going to be healthy eating everything on the planet. It's much like if you were driving a hot rod and you put the lowest possible octane gas into that car. It's going to run, but it's going to run badly.
Right. Okay. But add to that that what's occurred, particularly with glyphosate, which for everybody is Roundup, it's produced by Monsanto, is literally being sprayed over almost all the grains that people are eating right now. And so there's a lot of evidence. You hear all this talk about gluten sensitivity, and some immunologists say, "Oh, it's all bullshit. It's not true." Da, 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 da.
It's the Roundup they're saying. Yeah.
Well, first of all, I don't think it's BS because we take people off of that and we see it, and we see the immunological reactivity in testing. Sure. But there is some evidence that potentially some of that reactivity isn't all about the grain or the 13 different proteins inside of gluten, which need to be tested, by the way, but it could be that we're reacting to glyphosate. Right. So not to bag on vegetarians or veganism, but if you're a vegetarian because you don't want to eat animals, I totally respect
we get
that.
We understand that.
Totally. I don't like to either, but that doesn't mean that you then are going to support your body by eating out of a vending machine, right? You have to eat good, healthy, plant-based foods. But again, we're just talking about people who get sick and flip in that direction. I often find that when we're testing people, that foods are medicine for people, but they can also be the toxins that are actually making them really sick, right? When you eat a food, at the end of the day, that food breaks down into chemicals.
Yeah, let's talk about the difference between true food allergies and chemical sensitivities. Because I think that there's a myth out there that if you,
or food sensitivities, right?
Yeah.
So, everybody's familiar with kids who have peanut allergies, right? Yeah. You got to walk around with your EpiPen because that kid could kill. That's a true allergy.
Those are the real simple ones. But for a lot of people, they may eat certain foods that they don't even know is bothering them for days, weeks, or even months.
So that is the trick about food sensitivities that's often missed for people, and that is food sensitivities behave differently in your body immunologically. Let's just say you had, let's say you have a gluten sensitivity, and you have some bread.
Which I do.
And let's say you eat some bread on Sunday.
Yes.
You might feel fine Sunday night. You might feel fine Monday, Tuesday, Wednesday, and you eat sea bass and kale and spinach and water with lemon and stevia in it for the next 3 days, and you wake up Thursday feeling like hell. It could be a delayed sensitivity reaction to that gluten that you ate on Sunday because it could take 6 days or 7 days for it to act up. And here's the problem.
And your brain won't connect those because it's so far apart.
It's very difficult to do that. But also, the problem is that it could take 6 weeks to 6 months for that to wind down. I had a patient that I actually just saw a couple of days ago. She was given brewer's nutritional yeast from a nutritionist. It's
common.
She totally reacted to that. She's 6 months later still developing little hives. They almost look like bug bites on her skin from it.
Terrible.
She unfortunately has that genetic predisposition that's causing that thing to really, it's very difficult for it to get out of her system, right? So food sensitivities take longer to show up, and they often take longer to eradicate out of the body. So they're very, very tricky.
Tested.
So and they need to also be tested properly. That's right. So, we use a lot of really sophisticated labs that aren't of the traditional model, if you will.
Exactly.
That allow us to test for not only food sensitivities, but leaky gut, for fungal infections. So we do things like, I'm glad you brought this up, we do things like organic acid testing, we do immunological testing, we do stool testing, we do digestive testing, we run comprehensive blood panels on people.
Heavy metal detox.
Heavy metal toxicity, chemical sensitivities, bacterial, viral panels. So we can really look at what's driving that person's lack of health or their disease process or their sickness. And often it takes a little bit of investigative work. It isn't just obvious right on the surface.
Yeah, this is not your corner chiropractic center. I mean, the average chiropractic office that some of our patients have gone to, strictly spinal manipulation. That's all they do. Maybe they do a little hot pack, ultrasound, electric stim, something like that. But they're not doing the diagnostic work that it takes to get the results that we get.
Right.
They're not doing the neurologic workups. They're not doing the kinesiology work. To fully understand what you're really treating, you need to be able to test those things. So the beauty of the neurologic specialty that you're trained in is that, because I used to refer to neurologists and neurosurgeons, unless there's a drug or a surgery for something, they don't do anything at all. They do zip, nada. They wait for things to resolve if they will. So the beauty of your specialty is that you have something solid to offer the patients to bring them from wherever their status is at the moment, which varies greatly, I'm sure, to a more, better way of life.
Agreed. It's really fun. I mean, even the offices that we've been around who even have non-surgical spinal decompression, which we've been doing this since 2003. Yep. I think I was the first person to bring a decompression table to West LA. So what I've incorporated along with that and what we do along with that, I think is really the creme de la creme. It's what makes us so different. It isn't just about getting on a decompression table. It's all the other things that we evaluate and can treat along with that. But as it speaks to the neurology, I agree, right? So medical neurologists are really incredible diagnosticians. But then
they don't treat.
It's either drugs or surgery. That's all they can do. And the cool thing about functional neurology, one of my colleagues said it best. He said, listen, if you only have 2 nerve cells left and we can get them to talk to each other better, then we can improve your function, right? Yeah. And so it's so cool because everything that we do, everything that every therapist does anywhere is all receptor-based. You take a drug, it's receptor-based. You do physical therapy, it's receptor-based. You do acupuncture, it's receptor-based. You do psychotherapy, it's receptor-based. The work that we do is receptor-based, and what that means for patients is you have all these specialized nerve endings all over your body that are receiving information. Now, it's just our job as functional neurologists to look at where's the breakdown in the communication, what receptors can we activate to improve that function. So that might be that I need to do a timing thing with you on your lap. It might mean that I need to shine a light in your eye. It might mean that I need to do an optokinetic strip where I will look at red and white stripes. It might mean that I have you doing complex movements on one side. It might mean that we need to stabilize your eye movements in a particular direction of gaze.
Right.
I might have you gargle. I mean, there's literally infinite possibilities in the world of functional neurology, which is what makes it so exciting in terms of how to treat. And the cool thing is, you see results relatively quickly, typically with functional neurology. Not if somebody has, bashed their head and lost half their brain. That's not going to come back instantly, right?
Right.
But I had a woman who I treated,
or a stroke.
Or a stroke. Sometimes, it depends on the
Sometimes
severity.
it
depends on the severity of the stroke, right? But we can treat strokes. I'm glad you brought that up, and Parkinson's and things like that. But I had a woman who was involved in an accident. She was in a motorcycle and was pulling off at the freeway. Looked behind her, thought a car was going to hit her, and then just woke up on her back.
Right.
So she was knocked unconscious.
So it's safe to refer your friends, family, loved ones in who have had all those conditions.
Not only is it safe, it's the right thing to do because we can actually often improve them, right? So as an example, this woman I watched her walking down the hallway to me, and she walked and she was bent over like this and had to keep stabilizing herself. And when she got into my office, I had her just stand. I didn't even put her on the force plate. I just had her stand there and close her eyes, and she fell over. And she was an emotional wreck, of course, because she's not stable in the world. And it literally took 3 minutes to have her to do something, do some receptor-based activities, and she stood there and she closed her eyes and she went, "Oh my God, I'm not falling. Oh my God!" And then she cried tears of joy.
Isn't that great?
It's it's so awesome.
When you change somebody's life like that, it's amazing.
Now she still has.
That's why we do what we do.
True, but she still has a slowness of speech. I haven't brought that modality back yet. Yeah. But these are the kinds of things that you can have a pretty quick response to. And the cool thing is, it doesn't matter both you and I. There's 3 responses a patient is going to have, right? They're going to get better. They're going to get worse. Or there's going to be no change. That's just what occurs in any modality. But the getting worse here is what do we do that's going to make somebody worse?
It's pretty rare.
It's pretty darn rare.
Yeah.
We're doing decompression. Maybe somebody gets a little back soreness because we're activating muscles and tissue.
Sure.
It's like going to the gym for the first time in 10 years.
But it's short-lived.
It's really short-lived. Versus the risk that patients face when they're out in the traditional world of doing a lot of other modalities. The risks are often higher.
Or just drugs.
Yeah. I mean, how many patients have you seen where they come in, they've got a list of 16 different drugs, or
way
more?
Too many.
And how many of those patients have somebody who's coordinating the side effects of all those different drugs and looking at that to make sure?
Almost none.
Right. the danger of that
Right.
is just, it's craziness, right? They go to this is the world of divided specialties. You go to your cardiologist, you get your digoxin. You go to your your pulmonologist, you get something else, or you get your digoxin, you get your statin drugs, right? And then you go to your kidney guy and you get those drugs. And what happens is that their world is divided up into these different specialties, and it's not like your body is a beaker and you're putting a specific amount and you're going to get the exact same reaction every time. Everybody responds differently.
Sure.
And we see people who are on tons of medications who are really depressed as a consequence of the medication, or losing neurological function as a consequence of their medication, right? Or
Absolutely.
metabolic disturbances as a consequence, or gut issues, or joint issues, or all kinds of stuff. So, not that drugs are bad.
They have a place.
They have a place.
So does surgery.
Everything
But
has its place.
as the appropriate last resort or necessary resort given trauma.
Right.
Yeah.
So back to sort of what you said before, which
Yeah.
is take care of yourself now so that you don't end up in a situation where maybe a drug or surgery is your only choice.
Right.
But what I would like to say to people if they're listening, and hopefully you are, is even if you've been told that your only option is drugs or surgery, you won't know that until you have somebody like us take a look at you and
Properly
evaluate
them.
and evaluate you and go,
Right.
are there any options here? Maybe there is that you've never heard of before, because
Exactly.
gosh knows for the last 10, 15 years we've been doing that a lot for people. They've been told there's nothing we can do but have surgery, and we're able to help them avoid surgery. Right?
Many, 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 many times.
Indeed. I just wanted to have this sort of quick conversation with you and have people know a little bit more about what we do here in the office. And
And they can ask questions when they come in, and we're happy to help.
indeed, thanks for chatting.
Sure,
Appreciate
my
it.
pleasure. Glad to be here.
Nice to have you here, Jason. Thanks.